Good morning, I'm Dr. Scott Martin. I'm an interventional pain doctor by training. I'm also the head of the outside medical advisory board for Platinum Biologics. And I get asked this question all the time, both in my personal and professional capacity, but also from doctors who are either coming into the biologic space or they're already using a biologic from another company and they're trying to discern, well, why would I trade what I'm currently using for products from a company like Platinum? And we're going to answer some of those questions today. We're also going to go through kind of a very rudimentary protocol that I go through for every single patient. Now, I do a fair amount of consulting. I consult for 7 different biotechs. I've talked to probably 1,500 doctors over the past 2.5 years. I've taken 7 papers to publication in the regenerative medicine space. And I could consult for whoever I want, and I can use whatever product I want in my office. So why do I function as the head of the outside medical advisory board for Platinum, and why do I use their products? Well, I'm going to use 2 conversations I had just this morning to illustrate that example. First conversation I had was with a provider, and they were using a product from Vidi Labs. Good product, not saying anything bad about Vidi's product. And they wanted to go through a couple different patient issues. And so we went through the first patient's issue, patient with rheumatoid arthritis, chronic Epstein-Barr, also had some thyroid issues and diabetic. And I said, okay, what are you using? And they said, oh, we use this product from Vidi Labs. Okay, great. Next patient had a traumatic injury, was actually a hurdler and got back into hurdling as a coach and injured themselves while they were doing private training lessons for a collegiate hurdler. And I said, okay, interesting case. I haven't had a hurdler in a while. What'd you use? Oh, well, I used that same product. I said, all right. I said, acute injury, trauma, inflammation, right? I said, yeah, same product. I said, okay. They said, well, we have another patient as well. I said, okay, great. Let's talk about that patient. And that patient had just had a hip replacement and was having postoperative pain 3 months after the hip replacement. And they said, we use the same product that we used in both other patients. What would you have done differently? And it dawned on me that whoever was giving this doctor information, their protocol was just, no matter what is in front of you, hit it with the same hammer over and over and over again. And, they were informed to maybe use more, right? Depending on size of the patient or severity of the disease, just hit the screw harder with the hammer and it'll eventually go in, right? Second conversation was with another practice and they were using exosomes. And they're using exosomes for everything. And the paradigm was exactly the same. Well, we're using 1 trillion exosomes. Okay, that's fabulous. And, we've got a patient, and their first patient was a patient with pseudogout. And I said, okay, seems reasonable. Well, it's bone on bone with pseudogout. Okay, what do you use? Well, because it's bone on bone and it's pseudogout, we use 3 cc's. We use 3 trillion exosomes. Okay. I said, well, what if you do if it's just a garden variety patient walking in off, the street and they, sprained their ankle? Well, in that case, we would just use 1 cc of exosomes, 1 trillion exosomes. And I said, well, would you ever use something other than exosomes? Oh, no. We only use exosomes. And any of you who are out there practicing medicine in this post-COVID age, in 2025, the garden variety patient doesn't exist. I'm not seeing them. I'm seeing incredibly complex cases, patients with chronic autoimmune issues, advanced degenerative issues, all kind of swirled into one, soup, if you will. And they've had multiple different surgeries. They've had multiple different opinions. Maybe they've gone overseas for, quote, stem cells. And they're presenting with these very, very significant and complicated disease processes. And so why I use Platinum Biologics on my own patients is the very same reason that I consult for Platinum. Because they have 14 different products. Because as opposed to just being a dumb kind of monkey hammering everything with the same hammer over and over again, they have something that I call BI, Biologic Intelligence. It isn't emotional intelligence, it's biologically intelligent allografts that specifically address the nuances of disease. Now, we're going to be talking about this in terms of experimental use only, because as we know, right, and I'll say it in everything that I do, the FDA equals your friend. And because the FDA is your friend, we cannot use any biologic to diagnose, treat, cure, or prevent disease. We can use it for experimental use. And in states like Utah, California, they can be used a little bit more liberally, but only in the confines of cosmetics, orthobiologic pain, and wound. Now, there are probably 20 other states that are currently in the process of adopting very similar laws to Utah and California, but that hasn't happened yet. And even if it does happen, the FDA, again, is not going to just relinquish their oversight. They're probably going to increase their oversight. So part of the reason I use Platinum products is the number of varied and very specific products. The other reason that I consult for them is because the amount of education that they advocate from peer to peer, not rep to physician, from peer to peer. And I'm not talking about a PhD, no offense to the PhDs out there. I'm talking practicing physician to practicing physician within the same scope of practice. No one is doing a better or a more comprehensive job. Simply nobody. And I'm going to illustrate this point. And we're going to talk specifically about some of Platinum's products, some of their protocols that I was lucky enough to be part of helping develop. And I just want to follow with one last thing. For any of you who have seen me talk or present, for any of you who might be talking to me on the phone, I'm a consultant. I'm not an owner in Platinum. I have no financial benefit in giving this lecture, meaning I don't get paid if you order product. I don't make a penny off any of the reps that are out there moving product, right? My simple goal is to try to help you build a big, beautiful, bountiful practice. And if you want to set it up right across the street from me, and you want to jump on a peer-to-peer call and you wanted to use Platinum's products, I will help you build that practice literally right across the street. Because it's not going to take you and me, it's going to take hundreds of thousands of us to elevate the health and the health care of our communities. And so the more of us that are out there practicing safe, evidence-based, common sense biologic medicine, lots of folks are going to get better. Now, let's review kind of the nuance between kind of what you have to offer with Platinum as opposed to what you would have to offer with really any other biologics company. Now, just taking off the table the initial FDA risk, meaning that there are a myriad of companies out there that have warning letters from the FDA. If you are using a biologic, you should just simply type in the name of that company and FDA warning letter. And if you find a publicly available warning letter, what that warning letter means is that company, they haven't been shut down, but they have been cited by the FDA, probably for manufacturing or marketing issues where they are marketing to disease or saying their products can treat diseases or saying their products can be used in investigational drug studies to, again, treat disease. What it boils down to is that your practice is now on the radar with the FDA. I literally got a letter yesterday from a provider who was using a biologic from a company that I used to work at. That company made claims. I left because of those very claims, and their providers started to get warning letters because that company got a warning letter from the FDA. So when a company gets a warning letter from the FDA then gets access to all of the clients that are using that biologic. And if in that public warning letter it states that you as a provider are using an unapproved drug in the United States and you continue to use that biologic in your practice, well, you are using an off-label drug to treat patients in the United States. And rest assured, at some point, you're going to get a letter from the FDA. Now, that may just be a letter from the FDA, in which case you retain a federal attorney and you respond to that letter. Worst case scenario, the FDA sends you a cease and desist, and you can no longer practice medicine. Somewhere in between there is actually much more painful, where the FDA comes to your practice and they oversee your practice for 8 to 10 hours a day for 4 to 6 weeks. That's kind of like TSA doing a full cavity search on you 10 hours a day for 6 weeks. I can tell you it's profoundly uncomfortable. And now I've heard of multiple providers who have had to endure that pleasantry or unpleasantry. So, experimental use, number one. Number two, Platinum does not have a warning letter from the FDA, nor do any of the labs that they contract manufacture their products in. So let's walk through scenario A and scenario B. Scenario A is I'm using a biologic where the company says, hey, just use that for anything and everything, right? That's kind of scenario A over here, right? Here's scenario A, right? In scenario A, it doesn't matter whether it's a nail, it doesn't matter whether it's a screw, right? It doesn't matter whether it's a U-hook, it doesn't matter what it is, right? And everything here, you're going to use a hammer, right? And that company usually has a warning letter. And their reps or their PhD who's employed by the company and who does make money when you buy product, they're saying, well, just hit all of those things with the same hammer. And if you use more, you'll get a better outcome. Let me walk you through the alternative, because this is how I approach something as simple as pathology in the knee. Now let's just do a gentle review of the knee, all right? Femur, tibia, fibula. Your cartilage-based structures within the knee joint itself. The articular cartilage of the knee is type 2 collagen. The internal structures of the knee are type 1 and type 3. That means the ACL, the PCL, the medial meniscus, lateral meniscus, medial collateral ligament, lateral collateral ligament. All of those are type 1 and type 3 collagen. Now, if you were to use something like an autologous biologic, PRP, BMAC, stromovascular fat, you again are a one-trick pony. You have, so BMAC, PRP, SBF. What is the growth factor complex in all those? Type 1 collagen. That's it, right? It's only type 1 collagen. So if it's a complex pathology of the knee, you've got grade 3, grade 4 degeneration of the knee plus a meniscal tear, well, we just hit it with that old hammer, right? What if it's grade 3, grade 4 OA of the knee plus a meniscal tear plus an effusion? Yeah, we just hit it with the same hammer, right? Maybe harder, maybe add more volume, right? We're going to talk about volume in the knee in a second, all right? But that is one scenario. I think it's a very bad scenario, and I think it's very limited in overall efficacy. If I have 3 different types of cartilage-based degeneration of this knee, and I put in a growth factor complex that is only supplementing one of those types of collagen, type 1 collagen, meaning the body's only prayer is to go through collagenous differentiation at a cellular level and create type 1 collagen, which is fibrin, which creates scar tissue, which the body breaks down in 4 to 6 weeks. What is the possible hope for this patient to get both a robust and a durable response to that allograft application? I think it's rather limited, okay? And that's what we see in clinical practice. If we do PRP, maybe we get 4 weeks, maybe we get 6 weeks of relief, not much better than steroids, right? Some patients, if they don't have a robust immune system, what happens to them? Well, they get a persistent diffusion, right? What happens when you get a persistent diffusion? The inflammation can actually lead to apoptosis, to cell death of chondrocytes and synoviocytes. That's not what we want. That's bad. That's accelerating the degeneration of this joint. That's the last thing we want. So from an experimental use standpoint, using Platinum's products that have biologic intelligence, how might we approach a patient with, say, knee osteoarthritis? My approach is very, very regimented. First thing that I look at is their presence or absence of inflammation. If that inflammation is systemic, say this patient has OA of the knee, but they also have rheumatoid arthritis, you may consider systemically down-regulating that inflammation first. How do you do that? Well, you can use nano air, which is 50 billion lyophilized exosomes, and you can do that by nebulizer route of administration. You could also, when you mix that nano air with 3 cc's of normal saline, if you're in this Facebook group, I shot a video just yesterday demonstrating how to reconstitute that product. You could also reconstitute that product in 3 cc's and give it by IV route of administration. Beautiful, right? Nanosomes. Nanosomes is a cryopreserved product, 180 billion exosomes. The most potent exosome product in the regenerative medicine marketplace. This product was created by a colleague of mine, Dr. Ashim Gupta. This is the only exosome product on the market with peer-reviewed, published, PubMed indexed literature on how it was made. And for any of you, if you want that paper, your rep would be more than happy to send you that paper, and I will link the paper in this Facebook post. Nano Air Plus is also a product created by the wonderful Dr. Ashim Gupta. Nano Air Plus is a bit more concentrated than Nano Air. It's about 90 billion lyophilized exosomes. So specifically, this is cryo, this is lyophilized, this is lyophilized, this is lyophilized. From an experimental use standpoint, If I have a patient with significant inflammation in that joint, and they have systemic inflammation as well, in my personal opinion, if I want the body to go through uninterrupted collagenous differentiation at a cellular level, I have to eliminate the inflammatory component first, or at a minimum, downregulate it. Allow me this, right? If a patient is screaming at you at the top of their lungs that they're not going to pay their $20 copay, do you think they're going to hear any of your instructions for how to take the prescription you gave them? Not a chance. There's so much inflammation, there's so much volatility in that conversation. Whatever you're telling them about their prescription, they don't care about because they're upset about their copay. This is the same paradigm that happens in the body when you have unregulated inflammation. Your body's primary intent is to downregulate that inflammation because it's causing further damage to that joint. Only secondarily will the body go through collagenous differentiation, start to repair collagen superstructures, extracellular matrix, microarchitectural frameworks within a joint after the inflammation has been quelled. So this is always my number one. I always address inflammation first. And here, look, 3 different products to address inflammation from an experimental use standpoint. None of these predicated on body weight. None of them trillions of cells, which is ridiculous on its face. Okay, but this isn't it. This is just half the scenario. The other half the scenario, I'm looking at the cartilage-based defect. What is the degree of my cartilage-based defect? All right? Now we know the internal structures of the knee, type 1 and type 3 collagen. So if I have a patient with a sprain strain of this knee, and I'm just looking at stress, sprain, strain on the internal structures. I get an MRI, I see no tear in the medial meniscus, lateral meniscus. I see no tear of the medial collateral, lateral collateral ligament. But I see fraying, or I see some element of internal signal disruption in, say, the medial collateral ligament. What am I going to do? Well, I'd use something like nano jelly. All right? Nano jelly is cryopreserved, all right? Cryopreserved, and it's 70 milligrams of Wharton's jelly in 3 cc's. Beautiful product, turnkey, extremely affordable. More than likely half the price of the Arthrex or other PRP kits that you're buying, somewhere between $250 and $425 a kit. Now, remember, I still have to take into consideration the osteoarthritis and the inflammation that may be present. So if I have focal inflammation in a grade 1 or a grade 3 injury, I combine nano air and nano jelly. Remember, this is lyophilized, the nano air. I literally use my 3 cc's of nano jelly. I push it into my 50 billion vial of nano air, and I reconstitute them together and apply that to the knee. What a wonderful consideration from an allograft standpoint, and what an intelligent consideration from an experimental standpoint, except in Utah and in Florida, at least right now, to number 1, downregulate inflammation, and number 2, start the process of robust, comprehensive collagenous differentiation. Now, what if the defect is more significant? What if I've got not just derangement of meniscus, ACL, PCL, medial collateral, lateral collateral, but I also have degeneration of the articular cartilage of the tibial plateau or the femoral condyle, maybe subchondral cyst formation, those type things. That's grade 3, grade 4 osteoarthritis. Well, I need a more robust growth factor complex because I need a more significant amount of extracellular matrix. I use a more concentrated product as long as it's a non-surgical paradigm. In a non-surgical paradigm, I use 2 cc's of NanoFlex. That is 300 milligrams of Wharton's jelly. Now, my total volume, and this is really plus 1 cc of normal saline, right? My total volume for any large joint, I restrict to 3 cc's. And this is why you will see 2 cc's of NanoFlex and a cc of normal saline. In a degenerated knee, when this knee starts to collapse, a grade 3, grade 4 knee has collapse of joint space, contracture of joint space volume. Can I shove 4, 5, 6, 7 cc's of volume in that knee joint? I can. It's extremely painful. You're going to have to crank on the syringe to get it in. But what's going to happen to that patient when you distend the capsule of the joint, when you disrupt the osmotic potential within the synovial fluid? You're going to get a reactive effusion. Well, the reason we don't use BMAC, PRP, and SVF is because they work on a pro-inflammatory paradigm. They actually cause a reactive effusion as part of their mechanism of action. And we're using immune-privileged tissues, umbilical cord-derived tissues, specifically because they don't cause inflammation. So why would I stuff 3, any more than maybe 4 cc's of volume into this joint and risk a reactive effusion that's going to cause inflammation? And just like that patient screaming at you about their copay, who heard nothing about how to take their prescription, your body's going to work on the inflammation, and there will be very little, if any, collagenous differentiation. So I only use 3 cc's total volume. So in this case, with no inflammation, right, a grade 1, 2, and 3 cartilage-based defect, I'm using, because it's non-surgical, NanoFlex 2 cc's, 300 milligrams of Wharton's jelly, most concentrated product in the regenerative medicine space, plus a cc of normal saline. NanoFlex 2 cc's is cryopreserved. Now, what if this happened to be a grade 3, 4 OA, non-surgical, and that patient happened to have a slight effusion of that knee? They don't have systemic inflammation, they just have focal inflammation. What would I do? Instead of adding nano jelly to this paradigm, I would still use 2 cc's of NanoFlex and a cc of normal saline. And if it was inflammatory, right, I would add my nano air. And I would reconstitute 2 cc's of NanoFlex and a cc of normal saline with nano air. Now, in that knee, I'm putting in 50 billion exosomes, 300 milligrams of Wharton's jelly, and a cc of normal saline. And my total volume is still only 3 cc's. Pretty impressive, right? Pretty intelligent, experimental application of biologics. Now, what if I have more advanced disease? What if I have grade 3, grade 4 degeneration of this joint, and I have a bucket handle tear of the medial meniscus? Assuming that there's no inflammation, I combine an extremely concentrated aqueous growth factor product called NanoFlow. NanoFlow is 40 million MSC-derived growth factors, and it's in 1 cc. This is also cryopreserved. So going back to my 3 cc paradigm, if I had a surgical lesion, meaning I've got a patient with a bucket handle tear of the medial meniscus plus grade 3, grade 4 OA, where I've got degeneration of the articular cartilage, the internal structures in type 1 and 3. Now I've got defective collagen type 2, defective collagen type 1, defective collagen type 3. I'm going to use my NanoFlex, but I'm also going to add a cc of NanoFlow. 3 cc's total. 300 milligrams of Wharton's jelly plus 40 million MSC-derived growth factors. Now, how do we apply these biologics? I use an application interval of 0, 4, and 10 weeks, meaning my first application is time 0, then 4 weeks later, then 6 weeks after the second application. I don't know about other companies, but I follow some pretty strict precautions. I encourage no NSAIDs 3 days before an application or 7 days after, because NSAIDs will denature a biologic. I encourage nothing that's going to cause the patient to sweat for 48 to 72 hours. That means no pickleball, no running, no infrared sauna, no hot tub. For me, no road biking. For 48 to 72 hours after, because you're just going to sweat the biologic out. I also recommend no lidocaine, because lidocaine is immediately cytotoxic to stem cells. It also impairs collagenous differentiation for up to 2 weeks after application. Now, I do have another relative precaution. I'm not a huge fan of anything that's going to cause inflammation for 7 days on either side of this application. Some of you are going to use red light therapy. Some of you will use shockwave. Some of you may use hyperbaric oxygen or ozone or prolotherapy, or you may use PRP or BMAC in an algorithm with how you apply your biologic. All of those things cause inflammation. And so in my estimation, again, just like that patient screaming at me about a copay and not listening to what I'm telling them about a prescription, I don't want anything to interfere with my collagenous differentiation. So if you're going to use anything that's going to cause inflammation, please do it 7 to 10 days before or 7 to 10 days after the application. My preference is I like to ride the wave. What do I mean by that? If I'm using shockwave, I'm a podiatrist or a foot and ankle orthopedic surgeon, right? From 0 to 7 days, you're going to see a spike in the inflammatory cascade. Over that period of time, what is also going to rise is the chemotactic response from the body's own stem cells from your blood, from your bone, from your fat. They are going to rise as well. All right? But at that 7-day mark, your inflammation starts to wane over the next 10 to 12 days. Well, what about all of those wonderful stem cells from your own bone, from your own fat, from your own blood? Well, at about this time is when I apply my biologic, because the inflammation is on its way down, but all of those great MSCs are moving into that area to stimulate collagenous differentiation. And so if I put in an intelligent biologic and I have a complex cartilage-based defect, say I have defects of collagen type 1, 2, and 3, if I apply my biologic 7 to 10 days after I've done my shockwave, I already have all my growth factors en route. The wave is just about to crash. I literally just have to paddle into the wave. I just apply my intelligent biologic with comprehensive collagenous growth factors, and I'm going to get very robust collagenous differentiation. As opposed to applying biologic here, where the inflammation is going to denature that very same biologic. Now, I don't know what other companies have advised you on. I have no idea what kind of protocols they would give you. This is something that I go through with every single provider, from physicians, assistants, and nurse practitioners to neurosurgeons and everybody in between. Because at the end of the day, if you're not using a smart biologic and you're not applying it in a smart way for experimental use or cosmetic, are you going to get the outcomes that you want and your patients want? You probably aren't. So why do I consult for Platinum? Why do I use their products in my office? Because it's the most intelligent biologic out there. It's applied in the most intelligent way. And physicians educate other physicians and ancillary medical providers on a national level the way it should be done. I'm Dr. Martin. Please have a very blessed day.